Good afternoon, everybody, and welcome to this webinar that's going to be on lower GI bleeding today. My name is Mark Bignell. I'm one of the consultant surgeons at Oxford University Hospital. May I take this opportunity to thank both the college and the RSA network for supporting these webinars. And may I introduce Stephen Boyce, who's going to give today's webinar. He's a colleague of mine at Oxford. He's very experienced in colorectal surgery, and I'm sure we'll have a lot of useful things to say on this topic. We will be using the question and answer facility again at the bottom. Ask me questions as we're going along. I will answer them as we go. Any that you feel are particularly good, vote up, and then we'll share them with everybody, the whole audience. The next webinar, just following on from this, will be upper GI bleeding, and that's on the 7th. And without ado, I'll let Stephen take over.
So thank you for joining me this afternoon. I'm going to talk for the next 20 minutes on lower GI bleeding. Thank you, Mark, very much for your introduction. So, lower GI bleeding. Let's talk about the scale of the problem. So if we're looking at all GI bleed, that's upper GI bleed and lower GI bleed, there are approximately 85,000 cases per year in the United Kingdom. And that means one patient admitted with a gastrointestinal bleed in this country every 6 minutes. So it's common. Lower GI bleeding, by which I mean beyond the duodenum essentially, is 3 times less common than upper GI bleeding. And if we look at all the emergency admissions we have in general surgery, it's about 3%. So it's not a massive number of cases, but the morbidity and the drain of resources, the use of resources is significant. So the subject has been reviewed recently because of some poor outcomes amongst those with lower GI bleeding. If you look down here in the left corner, CPOD is the Confidential Inquiry into Postoperative Deaths, which is an organisation that looks at poor outcomes in emergency surgery. They reviewed the care that these patients are getting and found in a number of ways it was suboptimal, particularly the availability of acute endoscopy and radiology for these patients. And there's also been an audit of the amount of blood these people are given, and that was found again to be slightly over excessive in the amount of transfusion that these people were given when they were admitted. So I would point you to a very, very good review in the subject by Catherine Oakland. So this is published last year in Gut. So if you just search for lower GI bleeding, Oakland, Gut, you'll get this review and recommended. It's very good. So in terms of the severity of the problem, as I talked about the scale of the problem, so the mortality for these patients is about 3.5% for those who are admitted through the front door. Though if they develop a lower GI bleed while they're in hospital for some other cause, then the mortality is very significant. So the requirement for blood transfusion, about 20% of those cases admitted will be transfused blood. And the majority are admitted to general surgical wards. And these patients are usually elderly, and they usually have a high burden of comorbidity. And their mortality is generally related, not necessarily to the bleeding, but to the comorbid other illnesses. They don't tend to bleed to death, but they die from other complications. So I'm sorry, this is a bit of a busy slide. We're just going to go through some causes of lower GI bleeding. So in the UK, the take-home message is the commonest cause is diverticular disease. But in 60% of these cases, the bleeding can be severe. The second most common presentation, which might come to attention of the surgeon through A&E or ambulatory units, but may well be discharged, is anorectal pathology such as hemorrhoids or ulceration or fissures. Generally, hemorrhoidal bleeding is not severe, unless people are anticoagulated. And usually, if you get brisk lower GI bleeding, you shouldn't attribute it to hemorrhoids, and you should look for a second cause. Angiodysplasia was always quoted as being a very common cause, but my experience is actually quite rare. Angiodysplasia are usually found in the right side of the colon. Other causes of bleeding in the rectum include pelvic radiotherapy for prostate or cervical cancer, and other causes of bleeding, but usually not exsanguinating hemorrhage, are colitis, colorectal cancer, and polyps. And sometimes post-polypectomy, people will come in with lower GI bleeding. But interestingly, of the people that come in with lower GI bleeding, about a quarter will go home without a diagnosis. So from the top, this is diverticular disease, little diverticulae in the sigmoid colon. On the top right, this is a colon cancer. Bottom left, this is colitis. This is ischemic colitis. And on the bottom right, this is an angiodysplastic lesion in the right colon. So if we go through those causes in a bit more detail, diverticular disease. So it's common, most of us will get diverticular at some point in our lives as we get older. Very common, most people in their 80s have them. They're rare under the age of 40. About 3 to 15% of people with diverticular disease will get bleeding. And it's the commonest indication for mesenteric embolization, which is a treatment for lower GI bleeding, which we'll come to in a bit. The important thing to remember about diverticular disease is it is common. The bleeds can be severe, but in most cases it will stop. So in most cases, conservative management, it will stop. So there is a risk of bleeding. Okay, so this is a close-up of a diverticulum, and this is the theory that you have these little vessels that permeate from the colonic mesentery, and they come through the colonic wall, and where they come through, the theory is that they leave a little bit of a weakness in the muscle of the wall, and that then with sustained increased colonic pressure causes the diverticulum to get bigger and bigger, and then these little vessels, as they come through the diverticulum, are supposed to be susceptible to bleeding. So that's the theory about diverticular bleeds. Colorectal cancer, although relatively common in this country, doesn't usually present as an emergency with lower GI bleed unless the patient's anticoagulated. Even then, the bleeding is usually slow. There's often a background of comorbid symptoms, and often there's associated chronic an anemia. Polyps, when they're removed, can bleed and can bleed post-polypectomy. So these little angiodysplasias are said to account for about 40% of lower GI bleeding. I'd be interested in what Mark thinks, but that's not my experience. It's usually much more rare than that, though actually they're very difficult to diagnose because they're small and they're flat. These are acquired lesions with progressive dilatation of the blood vessels which sit in the submucosa of the intestine. They are common, well, more common in the elderly, and they're also associated with aortic stenosis and renal failure, and they tend to bleed from the right side of the colon. So those are some of the causes, and so when patients present with lower GI bleeding, our priority, of course, has to be assess the patient and then stabilize the patient who may be bleeding. And this is a situation which hopefully you will see very infrequently: massive amounts of blood, massive amounts of blood products, quite a large amount of blood on the floor. So we need to assess and we need to stabilize. So you should be familiar with the principles of the airway, breathing and circulation. And then the pertinent features of the history. It's very useful to know if the patient's had a previous colonoscopy, so you know what pathology they may have had long-standing. And are there any comorbid symptoms that might suggest a cancer, like weight loss or ongoing bleeding over a number of months. It's very important when you examine the patient to do a digital rectal examination. Can you feel any pathology? Is there blood actually when you examine them, and is it fresh blood or altered blood? Really, we should be doing a rigid sigmoidoscopy, which should be something should be available to all general surgical registrars or fellows on tape to have a quick look in the bottom and see what you see. And then you need to assess and resuscitate the patient. So that's about IV access, taking some bloods, cross-matching or group and save, and check coagulation profile. As we'll talk about soon, a lot of these elderly patients are often on multiple antiplatelets and anticoagulations. In the exsanguinating patient who's unstable, we would definitely give tranexamic acid and think about reversing anticoagulation. So I think a very important take-home message here is that lower GI bleeding is a multidisciplinary problem. It won't, as I said from the first slide, a lot of these people are admitted to surgical wards, but actually very rarely do they come to surgery. So I'm going to say that again. So very rarely do these people require operations, but they're all managed by surgeons, and we need a lot of help. So the very sick people who are bleeding, exsanguinating, may well be managed in ICU or taken to ICU. We definitely need our radiology colleagues early. We definitely need our gastroenterology colleagues. We may need a hematologist if the patient's on a number of anticoagulants and we want to stop or reverse them. Often these people will have cardiac comorbidities, and we may need to have a discussion with the cardiologist about stopping their anticoagulants, particularly antiplatelet medications. Very rarely will they come to surgery. So when you assess these people and they've got blood pouring out of their bottom, you need to ask the question, is this an upper GI bleed? So is there anything in the history that might suggest it's an upper GI bleeding, whether that be non-steroidals or a history of alcohol excess or cirrhosis? Because you look very silly if you miss an upper GI bleed and you arrange colonoscopy. So if there's any question there might be an upper GI bleed, then you arrange an upper GI endoscopy. This is a big ulcer here in the stomach with a big arterial blood squirting out of it. So that will very quickly pass through the GI tract and may appear like altered blood. This is a varix at the bottom of the esophagus. So you can imagine the blood that's pouring out of here. So in terms of management, we need to think about the anticoagulation early. So as I said at the start, diverticular disease is the commonest cause. And in diverticular disease, most of them will stop spontaneously, but they're not going to stop if their INR is 8. So very quickly, you need to think about their anticoagulants. And the recommendations would be that the warfarin should be interrupted or reversed if the patient is unstable. If there's a strong indication for warfarin, for example, mitral valve or atrial fibrillation with valve disease, or very recent DVT or PE, then you might consider bridging heparin after stopping the warfarin. If the patient is on dual antiplatelet therapy, which there might be, for example, for bare coronary stents, don't stop it unless you have a conversation with the cardiologist and unless the patient is exsanguinating, and then you need to speak to the cardiologist. The trade-off there will be stopping the anticoagulants and they're clotting off the coronary arteries and dying of an MI or of the bleeding. DOAC medication, so these direct oral anticoagulants have been challenging because until recently there's no antidote, so you just had to wait and hopefully the patient will stop bleeding. But in general, they should be stopped or interrupted, and sometimes now in some of most medications there are antidotes which can be given. So you need to involve your hematologist early, whether that be ordering blood products, or discussing the management of coagulation. So this is a bit complicated, I'm sorry about this, but this is actually a very good algorithm which is in the Oakland paper. So please look up the Oakland paper when we finish, because this is great. So essentially, if we look at the top of this management algorithm, essentially it's about assessing the patient and resuscitating, which we've already discussed. And then this is actually very useful to differentiate between, on the left, the unstable patient and the stable patient. We're going to calculate what's called the shock index, which is very simple, which is just the heart rate divided by the systolic blood pressure. And if that's greater than 1, which means their heart's pumping and their blood pressure's down, they're considered unstable. And if it's less than 1, they're considered stable. So I'm just going to go through that in a bit more detail in a minute. So assess them, calculate the shock index, and help you to assess whether or not they're unstable or if they're stable. So if they're unstable, an unstable GI bleed goes straight to the CT scanner and gets a CT angiogram. And if they're stable, you can calculate something called the risk score. So I'll come to that in a moment. This is the Oakland risk score, and this will allow you to decide whether or not to send the patient home without patient investigations or whether or not they should be investigated as an inpatient. So if they're investigated on this stable algorithm here as an inpatient, they'll have a colonoscopy. If they're unstable, they go straight into the CT scanner. So this is the shock index that I mentioned. So this is the heart rate divided by the systolic pressure. I mean, this truthfully I don't use very often. I was using it the other day, essentially with somebody with PR bleeding. So it's very simple: heart rate divided by systolic blood pressure. Okay. So if your heart rate is double your systolic blood pressure, then you've probably lost close to 3 liters of blood. So it's pretty simple. If your shock index is less than 1, then you're going to have lost less than 1 liter. You can be considered relatively stable. So let's go back to the algorithm. So if your patient is unstable, they go to the CT angiogram. If they're stable, you're going to assess whether or not they're fit enough to go home or should be investigated as an inpatient. So if you're investigating them as an inpatient, this is the stable patient. You'd use the Oakland score for safe discharge. This is a young woman who did a lot of young doctor who did a lot of her research in Oxford, and I think a few people of her seniority in medicine who've got a criteria score named after them. So this is very easy to find on the internet, and you just put in some of the physiological criteria to work at what their score is. So if they're stable, you do the Oakland score. If they're considered to have a major bleed, then you prep them and do an endoscopy when they're in hospital. If it's a minor bleed, you can safely arrange for their discharge. So which investigations are you going to do? Well, in the stable patient, you do colonoscopy. In the unstable patient, you do CT angiogram, and that will then, if positive, lead on to a selective mesenteric angiography. And then in terms of their treatment, most of them, as I said, will be diverticular and most will settle. In an unstable patient, you're going to do the CT angiogram. If that's positive, you're going to get a selective mesenteric angiography, and potentially your radiology colleagues could embolize it. Or you might consider therapeutic endoscopy if you've got access to the right skills. If your radiologists can identify where the bleeding is coming from, you might operate and remove that section of the bowel, but this is rare, and these people do really badly. And your treatment for the stable patient is endoscopic and potentially endoscopic intervention. So this is an example of CT angiography. This is a CT scan. These little black bubbles here are diverticularly on the colon. This is extravasated contrast. So contrast has been given into the main blood, into the veins. It's in the blood vessels, come out of the blood vessels into the lumen of the bowel. So that's a positive CT angiogram. So that means blood is pouring into the colon. Here it is again. This is before the IV contrast is given. So you give the IV contrast, you can see it here in the blood vessels, and then you can see it here in the lumen of the bowel. So this means blood is going into the lumen of the bowel. So this is a positive CTA in the sigmoid colon. So if you've got a positive CTA and the patient remains unstable, then you might proceed with selective mesenteric angiography. So this is a cannula that's gone up the right femoral artery into the aorta, and this is the inferior mesenteric artery. So here's a question to say who's awake and who's gone to sleep. So this is the inferior mesenteric artery. Okay, so these are the branches of the inferior mesenteric artery. So this is an artery that runs up along the side of the colon and runs right up here to the splenic flexion, around the corner to the transverse colon. So which vessel is marked by the black arrows here? Is it the celiac axis, the superior mesenteric artery, the inferior mesenteric artery, or the marginal artery of Drummond? So make your pick. Is it A, B, C, or D? Oh, very good. So 47% of you are correct. That is the marginal artery of Drummond. So the marginal artery of Drummond makes all colorectal surgery possible. And then we can take out a segment, divide the main IMA if we're doing a cancer resection for the left side, or we can rely on the marginal artery of Drummond to supply what's left of the left colon. Okay, good. On we go. Marginal artery of Drummond. So selective embolization, here we are again. So this is the inferior mesenteric artery. This is a sigmoid branch. And you have to look very closely, but these little tiny fellas here, those are coils which have been placed by our radiology colleagues to prevent the bleeding. And that's a magnification of the same slide. Isn't that amazingly clever? So as I said previously, therapy, surgery, emergency surgery is rarely performed for lower GI bleeding. This is the recommendation. That no patient should proceed to emergency laparotomy unless every effort has been made to localize the bleeding by radiological and endoscopic modalities. So what you don't want to do is end up trying to operate on a patient where you have no idea where the blood is coming from, because that can mean you take out the wrong bit and you send the patient back to ICU with blood pouring out of an ileostomy and the patient's got no colon and you've missed the bleeder. So here we are, learning points. Lower GI bleeding occurs in the frail, the elderly, and the anticoagulated patient. Bleeds can be severe. Diagnosis and treatment can be complicated. Your management algorithm is resuscitate the patient, identify the unstable patient, and involve other specialities early. So we're going to have some quick true or false quizzes. See who's been listening. In patients with coronary stents on dual antiplatelet therapy who present with lower GI bleeding, both drugs should be stopped immediately. Is that true or is it false? True or false? Very good. Yes. So the majority absolutely of you are right. Okay. So if your patient comes in with dual antiplatelet therapy, you should not stop both drugs. You should not stop both drugs until you talk to the cardiologist. If you speak to the cardiologist, he will say, maybe stop their clopidogrel, but don't stop their aspirin. If you stop both drugs, the likelihood is they'll clot off their coronary arteries and then have a massive heart attack. So don't stop them both immediately. I speak to the cardiologist. So false. Don't stop both drugs until you consult. Okay, next question. True or false? In patients with an unstable lower GI bleed, the first diagnostic test should be selective mesenteric angiography. So is that true or is it false? True or false? Okay, that's good. So yes, the majority of people are correct. This is false. Okay, so in patients with an unstable lower GI bleed, the first diagnostic test should be CT angiography with selective angiography embolization if positive. So in unstable lower GI bleed, the people that you put them into the CT scanner, and if they have a demonstrable bleed on the CT scanner, then they're the selective mesenteric angiography. Selective mesenteric angiography is an intervention. All interventions carry risk, and you don't do any intervention that carries risk unless you've got a therapeutic target. Okay, good. Final question. True or false? Colon cancer is the commonest cause of lower GI bleeding. True or false? Yes, very good, very good. So I said it again and again. So you're absolutely right. So diverticular disease, certainly in the United Kingdom, is the commonest cause of lower GI bleeding. Okay, well, thank you very much for joining me this afternoon. I hope that's been of some help. I would strongly recommend that you read the Oakland paper in Gut from 2019. It's a very, very good review of the subject. Thanks very much, Mark, for joining me. I hope you're ready to answer any of the very difficult questions.
Yeah, there's a couple of questions. I've managed to answer a few of them as we've gone along. One person's just asked, can you put your learning points slide back up? One from a few slides back.
Did I make a mistake on it?
No. I think they wanted to just get a screenshot. I think they've been frantically scribbling. That's
Okay.
perfect. Thank you. And then we've had a question, and it sort of, I'll add a second question onto it. The question is, do patients with lower GI bleeding need bowel prep for endoscopy?
So good question.
And then going on from that, what do you think is the benefit of an inpatient colonoscopy? Or
Well,
when do you think we should use them?
Well, that's interesting, Mark. I mean, that review paper from Oakland really pushed colonoscopy as both a diagnostic and a therapeutic intervention. I mean, I don't think I've ever managed to do a kind of therapeutic intervention with colonoscopy for bleeding, but the argument really is that maybe our gastroenterology colleagues should be getting a bit more involved in helping stop some of these bleeds endoscopically. I mean, it looks very, very challenging to me. The recommendations are usually for mechanical things like pressure with injection or down the scope clips. So I suppose maybe there were three questions there. Should they be prepped? If they're stable, they should be prepped if they're stable and require an inpatient scope, they should be prepped and scoped while they're in hospital. If they're stable and according to the Oakland score, they can go home, and then obviously they'll be prepped before they come back. If they're really bleeding and you feel confident you've got somebody who can potentially provide therapy, then usually people who are really bleeding don't need prep because the blood is so cathartic that it just goes straight through the GI tract.
Yeah.
Is that kind of an answer?
Yeah, no, that's always been my experience, is in the unstable patient, you haven't got time to prep them, but also you don't need to. Excellent. And then another question we've had is, could you just go over who can be ambulated and what sort of are the criteria for safe discharge?
Yeah, so let me just essentially this is the ambulatory pathway. So if I just go back one, so on the left, these are unstable patients. So the unstable patients you're going to identify essentially by a clinical assessment, but also by calculating the shock index. So these people are hemodynamically stable as a result of bleeding. So those people will go into the CT angiogram. The people who are considered stable, who are not shocked, who are not physiologically deranged because of their bleeding, can be considered stable. And those people, you can make a decision about whether or not they can go home, or whether exactly for safe discharge, or whether they should stay and have an inpatient colonoscopy based on the Oakland score. So the Oakland score is just is a little online calculator, and that will tell you who can go home and come back with colonoscopy, or who should have a colonoscopy while in hospital.
Excellent. I mean, in my experience, the majority of the patients from a bleeding perspective can actually go home.
Yeah.
It's their medical comorbidity, as you alluded to in one of your earlier slides, is the problem, what keeps them in hospital.
Yeah, no, I think
the majority are elderly and frail and live alone, and it's not safe to discharge them, rather than a hemodynamic problem.
Yeah, no, I think you're absolutely right. I think, as you said, that would fit very much, your experience, Mark, would very fit much with the national findings, that when these people do badly and they die, it's usually as a complication of their other medical illnesses. And that's why I think it's really important to involve other specialities. We're lucky in Oxford that we've got a very good what's called peri-op team, so a team of physicians who see our patients regularly. And certainly things around complicated coagulation, people with heart disease who are on multiple anticoagulants, we'd have that conversation together, because that's about assessing a risk, isn't it? A risk of bleeding versus the risk of thrombosis.
Yeah. And I think we've taken it one step further in Oxford, and we're trying to run all the acute bleeds through the ambulatory unit, but the medical ambulatory unit.
Yeah. Well, actually, that's interesting, because that was absolutely, Mark, that was one of the national recommendations, that there should be one source or one point of control for all GI bleeding. I mean, it's a nonsense really to separate upper GI bleeding from lower GI bleeding and have two specialities do it, rather than bringing expertise together. And as I said, rarely do these people come to surgery.
Yeah. And then we've got one sort of final question. Well, there's two questions, but I'll put them into one. There's been a question about aortoenteric fistula. Yeah. How do we know that it's an aortoenteric fistula clinically? And I suppose going on from that is, how do you know it's an upper or lower GI bleed just on when you sort of see them in the clinic?
Good question. So aortoenteric fistula, having seen maybe 2 or 3 in my life, it's usually terrifying.
Yeah.
But almost invariably there's a history of previous aortic surgery.
Yeah.
So usually the history is previous aortic surgery, sometimes complicated, sometimes they may have had a perioperative infection, but usually it's a big scar in the tummy, aortic surgery, and horrific bleeding, as in liters and liters coming out their bottom rapidly. So if you weren't sure of that, then you'd have an unstable patient. They would go to CT angiogram and they would diagnose it very quickly. I mean, I think it is a very reasonable question to say, how do you know definitely if it's upper or lower? You don't. I mean, you have to take a history. You get a suspicion. Sometimes people give a very good history of melena. Sometimes people give a very good history of altered anorectal blood, and you have to PR them. But if there's any doubt, again, I think it's reasonable to do your CT angiogram, and if your CT angiogram shows a source in the upper GI tract, then that's your answer. If you do the CT angiogram and your CT angiogram is negative and you still don't have a source, I think it's very reasonable to do an upper GI scope, and our gastroenterology colleagues would normally be receptive to that. I mean, as I said, there's about a quarter of these people you don't make a diagnosis on admission. Some of them you make a diagnosis consequently when they've outpatient investigations. I mean, there is the whole subject of occult GI bleeding from an unknown source, which is almost a different subject in itself, but where it's really, really challenging to find a source in the ongoing bleeding. Things like video capsule endoscopy is very helpful. Radionuclides, red cell scanning is talked about a lot, but actually rarely done. Is that kind of an answer?
Yeah, no, that's great. I think that's everything. We've talked about prep. Finally, one other question. How many episodes of bleeding would you consider requires somebody to be admitted?
I think that's probably possibly an oversimplification.
Yeah.
I mean, I think if you had a
I agree.
25-year-old who's bleeding when they go to the toilet, you wouldn't consider admitting them. You know, an 85-year-old who's on warfarin, I think, you know, one bleed might be enough. So without dodging the question, I think that's probably that's just one aspect of the management of these patients.
Yeah, no, I agree. I think frequency of bleeding, it can be very misleading.
Yeah.
As you say, the blood often is mixed in with the stool and acts as a very powerful laxative. So it's very difficult to qualify how much blood they've actually lost. And I think you have to go whether somebody's stable or not, rather than number of bleeds per se.
Yeah.
Okay. Right. Well, I think that's everything, Stephen. Thank you for that. That's a brilliant talk, and some excellent feedback has been received. So that's the end for today. Just to remind you again that on the 7th of July, here we are, it's just popped up, management of upper GI bleeding, and hopefully it won't contradict everything that we've just said today. Okay, thank you all.